It's very hard sometimes to look in the mirror and say we can do things better, but it's very important, particularly when you're dealing with patient lives. We always have to strive to do better, such that the care that we deliver to our patients is better.
Welcome to MedAxiom HeartTalk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom HeartTalk. In today's episode, we explore why 4 out of 5 people don't know they have cardiovascular disease until they end up in the emergency room. Also, how digital technology can help ensure you are treating patients before it's too late. I am thrilled to introduce today's guest. Dr. Rahul Sharma is an interventional cardiologist and the senior scientific advisor for Egnite. So welcome to the podcast, Dr. Sharma.
Thank you, Melanie. Thank you for having me.
So we will learn more about Dr. Sharma's background throughout the episode, but please always check out his full bio in the episode notes. All right, so the first question we ask all Heart Talk guests, it is the hardest one of the day. Are you ready for it?
Ready.
All right, not hard at all, but why did you decide to get into healthcare? You know, we often ask, did you have an aha moment when you knew you were doing the right thing?
I'm not sure I had a typical aha moment. I think for me, it was more that I never really considered another career. I think a lot of people go through a crisis of trying to figure out what it is they want to do. I think for me, I just kind of always knew I wanted to get into healthcare. I always knew I wanted to be a physician. Part of that is that I have a lot of physicians in my family. And so I'm sure that played a big part in that knowledge that I really wanted to do that. Certainly, I didn't always want to be a cardiologist, but I think from the very beginning, when I thought about the idea of a career, medicine was always at the forefront.
Yeah, sounds like you didn't have a choice.
Oh, I certainly had a choice.
Yeah.
I just don't think I was drawn to any other career path as much as I was drawn to that of medicine.
Yeah, you had the role models all around you.
Absolutely.
Yeah, as a journalist, I want to talk about a few statistics. They're always very startling to me when we do stories on this, but these from the Centers for Disease Control and Prevention. One person dies every 33 seconds here in the U.S. from cardiovascular disease, and about 695,000 people in the U.S. died from heart disease in 2021. So we are talking 1 in every 5 deaths. So, Dr. Sharma, given these staggering stats, we can assume that a patient's time to treatment is crucial to saving lives. The time for a patient to get from an echocardiogram to a structural heart evaluation to an actual intervention is 193 days on average. That's according to recent Egnite data. So would you agree that change is long overdue?
Absolutely. I think that, every time I hear these statistics, as much as I'm deeply involved in cardiovascular medicine as part of my career and for that matter, my life, I think nevertheless, every time I hear these statistics, it's still just as alarming. And along those lines, I think most people aren't aware of how staggering those statistics are. And I think a big part of what we do, especially in cardiology, is all about the time to treatment, whether it's in the acute setting when someone's having a heart attack, the time from when a patient presents to the hospital and when we open up a blocked artery is critical. And so we actually measure that time as a metric. And so too is the time to treat more chronic diseases, which while less acute can still have a significant impact on a patient's morbidity and mortality. And so I definitely think that a change is long overdue. And I think, as we'll probably talk about in a bit more detail, just the approach that we take to identifying these patients with cardiovascular disease and then moving through the process of getting them to evaluation and then ultimately treatment. We've been doing it the same way for a long time, and I just don't think that's the most efficient way. And the use of digital health and a lot of the technologies, such as Ignite, have really helped to mitigate that delay.
Yeah, I mean, technology is there to shorten that amount of time. So we'll talk in detail about other potential solutions in a minute, but first let's kind of put this into some context. For a patient who receives an echo with severe structural heart disease, indicating that they do need to see a specialist, historically, what barriers tend to create an unreasonably long wait time, like we just talked about, until that patient actually gets an evaluation?
So I think there's a lot of points at which delays can occur. And if we start with the patient, ultimately the patient is at the center of all of this. It's the recognition by the patient of their symptoms, acknowledgement of their symptoms, and understanding that what they're experiencing is not a variation of normal. A lot of patients that we see in clinic will chalk up their symptoms that they've had for quite some time to, for example, just getting older, or in the context of the post-COVID era that we live in, just a deconditioning that they experienced through COVID. I think the first step is patients being aware and being educated and knowing what to look for, and then acting on said symptoms that they've recognized, and then going to see either a primary care physician or a primary care doctor or a primary cardiologist, who then recognizes those symptoms and then begins the process of evaluation. So I think that's the next point at which things can fall apart, is that the first physician they see needs to recognize that something's wrong and ask the right questions, perform the right tests, to then go to the next step. Once that structural heart disease issue is identified, I think the next step, and where a lot of the process breaks down, is the referral to someone who is a specialist who can then either further evaluate the issue or ideally treat the problem that's arisen. I think that's where a lot of times referrings may hold on to patients. And again, that may be because of a lack of education, a lack of awareness, or sometimes, unfortunately, in some cases, an unwillingness to share their patient out of fear that another physician or another health center may steal their patient, for lack of a better phrase. And then I think once they get into the hands of the specialist, again, it's the same idea of identification, further evaluation, and then treatment. And there are a whole host of barriers to why that doesn't occur in an efficient manner once they have reached that subspecialty care facility.
And I mean, as we're hearing, time is life in this case. As I do a lot of these stories, I know it's scary for patients, that initial contact, that something, and even like you're saying, to admit that something is wrong. And no, I'm just getting old. And, this is how I should feel at this age.
Absolutely. I think it's what we've got to remember is that for the patient, this is a very unfamiliar, unnerving, and quite frankly, at times frustrating pathway. Navigating the complex myriad of pathways, the different physicians, the different providers involved. You overlay that with insurance issues, authorization issues, particularly in this country, and it becomes very complex. And if there's a socioeconomic barrier, if there's a language barrier, if there's a cultural barrier, all of these can further compound what is already a very complex problem. And so I think as healthcare providers, trying to be cognizant of that is important along each of those steps that we just described.
All right. Well, we certainly have described and talked about the problem, but I do want to talk solutions. So, Dr. Sharma, ideally, what should that referral process look like? You talked about that being a barrier for a patient who has an echo with structural heart disease, indicating they need to see that heart specialist.
Yeah, I think that my mantra when I'm going out and speaking to existing or potential referring physicians is that you can never refer too early. And by that, I mean, if you refer a patient and their disease or symptom status is not advanced enough to warrant treatment at that point, there's no harm, but at least they're in our system, at least they're in our vision, and we can continue together with their referring provider, keep a close eye on that patient such that if and when they progress, either in terms of the severity of their disease or their symptom status, to the point they require treatment, we're ready and waiting, and there's no time lost. Because I think I and a lot of my colleagues would much rather that than the opposite, which is what we see in clinical practice, where a lot of these patients are languishing in outpatient care. And if they get to us, sometimes it's too little too late. And it's very frustrating because a lot of that is preventable. So in an ideal world, I think once a patient has been identified as having some sort of significant structural heart disease, my kind of recommendation would be to refer that patient as soon as possible to a specialty care center, a center that specializes in structural heart disease, where then either further evaluation might be needed to determine the true severity, further evaluation of the patient, or it may be that the patient has already progressed to the point where they go straight to treatment, and that can occur in a rapid and an efficient way. So for me, the message is really early referral. I think a lot of referring physicians feel like the onus is on them to determine exactly when to refer, and so they may hold on to patients a little longer than they should. I think a lot of referring physicians feel that the onus is on them to determine what the appropriate treatment is. And we have to remember this is a rapidly evolving field. And, while all of our referring physicians, I'm sure, are up to date with their medical education. Naturally, they're not going to be as aware of the latest and greatest in terms of devices and clinical trials, because this is what we do every day. And so that's the purpose of having access to subspecialty care. And so again, just that early referral to the subspecialty physicians and teams is critical to making sure that these patients do get treated in a timely manner.
Yeah, that makes sense. I mean, it may click a lot faster for another physician, that cardiologist, that specialist, than it would maybe for that initial physician. So we've established the problem and talked about some solutions, and we'll continue this conversation after a quick message for our Heart Talk listeners. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back. We have been talking with Dr. Sharma about some of the reasons why structural heart patients experience an unreasonably long wait time before receiving treatment. Also, some of the solutions, but let's talk about leveraging digital technology. We love it. It's a blessing and a curse at times, but we're going to talk about it in a positive way. How does that play a role in identifying heart disease earlier and also reducing a patient's time to evaluation? In other words, is there an app for that?
Yeah, I think that, digital health and for that matter, AI are terms that are thrown around ubiquitously now in every industry, and healthcare is no different. In some ways, there's a lack of understanding. I think in some ways, there's a misunderstanding. And in certain instances, there's a fear of the role of digital health and or artificial intelligence when it comes to healthcare. Obviously, one of the, elephants in the room, so to speak, is the issue of data privacy and HIPAA. And I think that's a lot of where fear comes from in terms of physicians or healthcare systems partaking in it. And I would say that a lot of the current existing digital health platforms have dealt with that data privacy issue incredibly well. But if we put that aside for a moment, I think the role really of digitization in healthcare is to improve efficiency overall. And when we talk about efficiency, we're talking about identification of these patients earlier in a more efficient manner when it comes to the large volume of patients we're dealing with. We know that technology is going to be a lot more efficient, a lot faster than humans can be in terms of identifying these patients. Instead of waiting for those referrals to come in, a lot of these platforms can identify these patients who are sitting in our healthcare database instantly. And then once they've been identified, I think the role of technology is to help us, not replace us, which is important, but to help us in improving that workflow so that once we've identified the patient with the disease process, we can then move them through that evaluation pathway in a much more time, cost, and resource effective manner, such that where appropriate, we can get them to treatment.
I want to kind of double back a little bit because you kind of touched on this, but let's talk about the importance of the physician and even nurses in ensuring patients do not fall through the cracks.
Yeah, I think it's critical. And that's where I don't think that, at this point in time, technology is going to replace any of the individuals who are part of the heart team, because you still need someone to facilitate the pathway or the journey of the patient. Even if there's a technology that can identify the patient, there might be an ancillary technology that can help you move that patient through, but you still need ultimately the physicians and the nurse navigators to see these patients, to coordinate their tests, to put it all together, to discuss all of this, to come up with a treatment plan, and then ensure that, again, where appropriate, that treatment plan is to put into effect. Someone needs to explain this to the patient. We need to consent the patient. We need to arrange for the patient to come in. We need to manage their perioperative state, their postoperative state, where is this patient going to go afterwards? What's their follow-up? How are we going to coordinate all of this care with that original referring provider? So all of this has to be managed by humans, and the importance of that human touch obviously cannot be underestimated, particularly from the patient's perspective.
Yeah, I think that's a really good point, especially when you're talking about people want to interact with people. We really don't enjoy having to talk to computers or communicate. Not everybody's going to get on a portal and have that conversation. So is there a specific program that you use?
Absolutely. So I've been involved with the CardioCare platform for about 3 years now, from Egnite. And initially, I came to be familiar with CardioCare when I was looking for a platform really just to manage all of my patients in one portal. I saw a need to make sure that patients didn't fall through the cracks, patients that we had seen and evaluated in different, I guess, points in their journey or pathway. I wanted to make sure that at any one point in time, we could easily identify where patients were in their individual journey. Were patients waiting inordinate amount of time for a particular test, or they'd had their test, but they hadn't been treated yet? If a referring provider reached out to say, what happened to said patient, that we had one place where we could easily identify where patients were. And that was the initial idea. When I discovered CardioCare, I realized that not only did it provide a platform to do that and to manage all of these patients in one sort of digital repository, but more importantly, arguably, it was also a tool to identify patients who had significant structural heart disease and other cardiovascular disease. And so we really moved a long way from my initial intent with the platform to now being able to use it to identify patients of interest, whether it's for commercially available procedures or for new cutting edge clinical trials, to be able to provide patients with novel devices and therapies, all the way to managing those patients on a digital pathway to make sure that once we've identified them, we're bringing them in for a efficient, rapid evaluation. We're utilizing tests appropriately and using tests which are a limited resource, for example, CT scans or echocardiograms on the right patients. We're filling our clinics with the right patients, making sure that we're using the resources of personnel appropriately as well. And then moving those patients along and either determining that we're just going to watch and wait, in which case we have them on a list to bring them back, and so they're not getting lost to follow up. If patients are appropriate to move forward, we're then able to put them on a pathway to treat them, whether it's through a clinical trial or through a commercially available therapy. And then we're able to monitor all of that in terms of the time taken for each of those steps to make sure that there are no lags in the system and everyone's getting appropriate care. And again, no one's falling through the cracks.
Wow, that's huge. Yeah,
absolutely. I think the other part is that it gives us a tool to really introspect and reflect on our own performance in terms of quality of what we're doing. For example, how long does it take us from evaluation to order tests for patients? Once we've determined a plan for them, how long does it take us to treat them? What is the quality of our imaging like? How often are our imaging team getting all of the right measurements as per the guidelines? And these are all really important. This QA approach to what we're doing, I think it's very hard sometimes to look in the mirror and say we can do things better, but it's very important, particularly when you're dealing with patient lives. We always have to strive to do better, such that the care that we deliver to our patients is better.
So CardioCare platform's allowing you to improve patient care, giving them access to those therapies. And I think, what I hear you saying is that accountability and noticing trends so that you can maybe address it differently if you're noticing you're missing something consistently.
Absolutely. And I think aside from anecdotally, I think we have the data to demonstrate and reflect the positive impact that CardioCare has had on our practice here. Our volumes have gone up across the board in all of the procedures we do. And that was in spite of COVID, where we saw a lot of healthcare systems at the very least plateau, but in most cases regress in terms of volume and then slowly come back. We continued to grow across the board. And a big part of that was because of the drive of patients identified through CardioCare. It's improved the ability for me to perform outreach in terms of coming back to educating those referring physicians, making them aware of what's new, what's hot, what are the new trials, what are the new devices. I can now do that for the most part digitally, because I can identify patients through this platform, identify who their referring physicians are, and then reach out to them and provide this education. But where it's now more impactful because I'm talking about a real patient. I'm not talking about a potential future patient. This is someone they know, they look after, and that's far more impactful. And we are seeing it change the culture. I'm now seeing these same referring physicians becoming much more aware of when to send a patient, what sort of patient to send, some of the new trials we're running. And, finally, I think speaking of trials, our enrollment in clinical trials has been excellent since the introduction of CardioCare. We're in the top layers of trial enrollers across the country. And a lot of that is attributable, again, to CardioCare identifying these patients who meet specific inclusion and exclusion criteria that suit this particular trial. And, that's really important because a lot of these patients, a lot of these referrings aren't even aware that these technologies exist for some of these newer indications.
Yeah, I want to say all the podcasts that we've done, all the physicians, cardiologists, everyone always is patient-centered. So to your point, hearing the story, knowing that it's affecting a real person, it seems that you would find what you're finding, that everyone's a little more receptive to that feedback and suggestions for change.
Absolutely. I think, we've had a very positive experience. I think initially there was some trepidation that when we launched this, perhaps some referring providers may feel like we're playing Big Brother, so to speak, and we're kind of telling them how to manage their patients. But in reality, that hasn't been my experience. I think like most things in life, it all depends how you package it and how you present it. And for us, it's just been a case of saying, look, we have a platform. It has helped us identify a patient who may be a candidate for a particular therapy or a particular intervention. And would you like us to evaluate that patient further? And I think any physician managing a patient who truly wants the best care for their patient would not say no to an offer like that. Mm-hmm. I think you have to be wary of anyone who gets apprehensive and doesn't wish to allow their patient to be evaluated further at a tertiary center with subspecialty care. And so for the most part, I think we've had a very positive reception to this. And at the end of the day, it's been better for the patients.
Mm-hmm. Which is the key.
Absolutely.
So can you dive deeper into the clinical efficiencies that you've seen?
Sure. I would say before CardioCare, maybe 75% of our patients would end up not needing any further therapy, either because they didn't have any significant disease, they were too early in their disease state, or they simply had nothing that was of particular relevance to our clinic. Now, the problem with that is that there's a significant inefficiency in the time spent in clinic seeing those patients. But there's also an inefficiency in terms of the resources utilized to get those patients there, whether it's from the nurse coordinators who bring those patients in, the time slot that they've taken up with that appointment, or for that matter, any testing that we may have done only to realize that there was no significant disease to be identified. I think what CardioCare has allowed us to do is identify the right patients. Now we've seen a change in that ratio and almost a flip where 75% of our patients that we see in clinic now will go on to have some sort of therapy. So it's a very enriched population. So now that means that the efforts of the coordinators, the nurses, the nurse practitioners, the schedulers are not in vain. We're actually seeing patients that we should be seeing. The tests that we're performing are now necessary tests. So we're not using up those test slots on patients who don't need them, and they're therefore taking away from patients that do. And then finally, all of the time that we're spending, those appointments are not going to patients who don't need them, but they're going to the right people. So we're seeing the right people at the right time, getting all the right tests done, and everyone's efforts are towards that goal of getting the right people treated.
Mm-hmm. What would you recommend next steps be for your peers considering CardioCare or honestly any other digital health platform?
Honestly, I think it's just be open, be receptive, be aware that these platforms do exist. I'm sure there are many more coming down the pipeline. And so be open to providers calling you and discussing that patients have been identified. And I think it's an opportunity for everyone to learn. It's a way to keep up with that continuing medical education because these conversations are a segue to talk about new therapies that someone may not be aware of, new disease states that we're now able to treat, less invasive therapies, new trials. There's, this almost gargantuan volume of information out there. And I feel like we're on this exponential curve, which is amazing of advancement. But what that comes with is a responsibility to stay on top of that and, keep up with the curve, which is very difficult. So I think just, again, just being open to the idea, being receptive to the idea and be willing to engage in a dialogue and a conversation, again, with the patient at the forefront, because that's the goal here. putting egos aside. This isn't about egos. This isn't about ownership. This is about getting your patient timely and effective and potentially life-saving care.
Yeah, what you don't know, you can't address. So this is an opportunity to learn more. And again, keep
Correct.
that patient first. All right, Dr. Sharma, thank you so much. This was a very great conversation, sharing your time, your expertise today with our MedAxiom HeartTalk guests. I appreciate you.
Thank you, Melanie, and thank you again for having me. It was an absolute pleasure.
All right, well, that is going to do it for this episode. If you liked it, please tell your colleagues and let them know they can subscribe to MedAxiom HeartTalk on Apple, Google, or wherever they get their podcast. If you would like to send us a note or suggest a topic, email us at hearttalk@medaxiom.com. Thanks for listening.